So there are some major changes in the diagnostic and treatment, some paradigm shifts. I will just touch the nutshells. The TB suspect term has been abolished with presumptive TB. Presumptive pulmonary TB is a person with any of the symptoms or signs: cough more than 2 weeks, fever more than 2 weeks, significant weight loss and hemoptysis, and any suggestive abnormality in chest X-ray, and special impetus to be given for diagnosis in special risk immunosuppressed and other populations. Presumptive EPTP is presence of organ-specific symptoms and signs along with constitutional symptoms, but we should try to achieve a microbiological diagnosis as far as practicable in these patients too. And the presumptive pediatric TB, the additional points are here that loss of weight or no weight gain and the history of contact with infectious TB diseases. These are also additional points to suspect presumptive TB in pediatric population. The case definitions, it has been simplified. Only microbiology confirmed, which refers to a TB patient whose biological sample are positive either by smear or by culture or by WHO and India government endorsed rapid molecular testing methods, means CBNAT and line probe assay. And the another P is clinically diagnosed TB case, which refers to presumptive TB patient where bacteriological or microbiological confirmation has not been achieved, but the treating physician stamps it as a clinically diagnosed TB based on symptoms, radiology, and other ancillary investigations. So only two types of case definitions: microbiology confirmed, clinically diagnosed. The drug resistant TB definitions has also changed. I will only highlight the important one. Rifampicin resistance or RRTB has been highlighted. It is a TB patient whose biological specimen has been found to be resistant to rifampicin, detected either by phenotypic or genotypic methods, with or without resistance to other anti-TB drugs. Why this has been highlighted? Because in program per se, RRTB has been given the equivalent status of MDR-TB. So RRTB should be treated in the same line as DRTB. And the pre-XDR and XDR definition has been modified with the abolition of injectable drugs. Now we have entered the era of all oral TB regimens mostly. So pre-XDR is a disease caused by Mycobacterium tuberculosis that must be MDR or RR at the baseline with additional resistance to any of the respiratory fluoroquinolones, means levofloxacin, moxifloxacin. And XDR, a TB caused by Mycobacterium tuberculosis, again, which must satisfy the MDR or RR TB with additional resistance to any of the fluoroquinolones and at least one additional group A drugs. That means either bedaquiline or linezolid or both. So these are the new pre-XDR and XDR TB definitions. Diagnosis, I will highlight on the rapid molecular diagnostic test, the nucleic acid amplification test or CBNAT, and the first and second line LPS. These are WHO and Government of India endorsed cases. The advantage is that the rapidity of diagnosis with high sensitivity and specificity. CBNAT, the diagnosis can be achieved in only 2 hours. And in LPA, the drug resistance we can get only within 72 hours. Where in liquid culture, the time is around 6 weeks. So this has put forward our fight. This has helped us. But one thing we should keep in mind, the genotypic test, that is drug resistant test, they cannot be used for determining treatment response. So CBNAT, LPA for diagnosis of drug resistance, they are fine. But they cannot be used as a follow-up test to see whether patient is improving or not. For that, we need drug susceptibility testing. So the TB treatment regimens which are available now, it has also been simplified. DSTB regimen for INH monopoly, shorter all oral MDR or RRTB, all oral longer regimen. So these 4 regimens are available now as per program, and one experimental in the pipeline BPAL regimen for XDR TB where no other treatment option is available with bedaquiline, pretomanid and linezolid 6 to 9 months. So let us see what is the diagnostic and treatment algorithm has been very much simplified. So all TB patients are undergone CVNAT. If CVNAT shows rifampicin sensitive, then we put the sample for first line LPA to see additional INH resistance. If first line LPA shows no INH resistance, then rifampicin sensitive, INH also sensitive, so continue treatment for DST. If rifampicin is sensitive but first line LPA shows INH is resistant, so we categorize it as INH monoresistant and we treat the patient as INH monoresistance regimen. Next, the other arm, CVNAT. The CVNAT side shows rifampicin resistance is detected. Then we send first line LPA along with baseline second line LPA with liquid culture DST to pyrazinamide, bedaquiline, moxifloxacin, linezolid and delamine. Part and parcel of universal DST program now. If no additional drug resistance is detected, then it should be it can be treated as RRTB by shorter regimen, all oral regimen. If any additional drug resistance is detected, then we should go for all oral longer regimen. So this is the protocol. This is DSTP regimen now. Again a change that 2 HRZE plus 4 HRE. Ethambutol has been added in the continuation phase. And another thing that has changed, the daily dose of drug and weight banding. There are 5 weight bands for adults, 25 to 34, 35 to 49, 50 to 64, 65 to 75 and above 75, and accordingly 2, 3, 4, 5 and 6 tablets per day. The tablets are fixed dose combination consisting of 4 drugs, rifampicin 150, INH 75, pyrazinamide 400 and ethambutol 275. And the continuation phase FDC contains 3 drugs, H, R and E. The CP may be extended for 3 to 6 months in certain TB like CNS skeletal disseminated based on clinical decision.